A warm welcome to all our webinar attendees and our expert speakers and the CANSA team. I am Dr. Brenda Kubheka from Health IQ Consulting and also a member of CANSA's Social and Ethics Committee. I'm looking forward to this afternoon's conversation about cancer patients and COVID-19 vaccination. I will be the facilitator for this afternoon's webinar. Please take note that in line with the POPI Act, this webinar will be recorded for CANSA's record keeping, and it will be shared on CANSA's online platforms at a later stage. By remaining on this webinar, you give CANSA consent to use your information for statistical purposes. Should you not consent to the recording or being identified by name in this recording, kindly change your display name settings or remove yourself from this webinar. We're very excited to be joined by two oncology experts and one advocate lobbying on behalf of people with non-communicable diseases, which includes those living with cancer. So today we are going to have presentations from our expert and advocate, and that will be followed by a question and answer session. Each speaker will be allocated 15 minutes and one will go after the other as explained. Please make sure that you use the chat box to post your comments and post your questions. And Lucy Balona from CANSA's head of marketing and communication, assisted by Emmanuel Peterson from EP Digital, will assist in managing the Q&A session. So feel free at any time to post your comments and questions. We will attend to them at a later stage. So right now, I'll take this opportunity to introduce our first speaker. Her name is Dr. Ria David. She was born and grew up in Durban. She completed her undergraduate studies at the University of Natal Medical School in 2002, and thereafter served her internship in Cape Town and community service in the deep rural KwaZulu-Natal. She discovered a love for internal medicine at McCourt Hospital, where she served 2 years as a medical officer. This led to a 7-year postgraduate journey at the University of Witwatersrand, where she completed her specialization in internal medicine, and then a super specialist qualification in medical oncology before returning to her hometown. Dr. David now practices oncology at Oncocare in Durban and Umhlanga branches of the practice. She has special interest in breast, colorectal, and hematological malignancies. She also serves on the executive committee of the Durban Breast Cancer Forum and the Cardio-Oncology Society of Southern Africa. So let's welcome our first presenter, Dr. Ria David. Thank you.
Thank you very much, Brenda, for that kind introduction. And thank you to CANSA for your warm invitation and for including me in this webinar. I think we're going to have a very interesting session. I'm also very excited to see so many of you that have dialed in for the session. I think it's going to be a good one. If we can please have the first slide up. Thank you. So I'm going to give you just a very broad-based overview to a guide to vaccination for COVID in oncology patients. This is by no means intended to be an exhaustive discussion. It's meant to introduce a few concepts and to familiarize ourselves with some of the international guidelines for patients in oncology who are wanting to be vaccinated for COVID. Next slide, please. So I'm going to cover first a little introduction on what is a vaccination. We will talk a bit about some interesting historical perspectives that I think some of the younger set in particular might not be aware of, with many vaccinations having eradicated or nearly eradicated many devastating diseases of childhood that we used to see in the 20th century. Then we'll talk a little bit about the COVID vaccines that are available. Are they safe? When should they be used? And a few guidelines for oncology patients. Next slide, please. So as a young child growing up, I actually remember a fascinating conversation with my mum regarding how vaccines work. Now, she is not a medical person. She was never medically trained, but it was just a particular interest of hers to learn about the human body. And going into medical school, I think these concepts were further elaborated and became even more interesting to me. So I think by way of introduction, it's important to recognize and realize that the immune system is incredibly complex. And it starts off with very basic components like mucosal membranes and intact skin barriers, to the innate and the acquired immune systems consisting of various white blood cells and antibodies as well. So in the development of vaccines, it's the basic concept and the basic idea is that one is introducing either the offending agent, the bug, the virus, in its live form or its killed form, or in some cases, components of that bug. And in doing this, it induces an immune response in the host or the human being to create antibodies that will then still be stored in the body and serve as a form of memory, so that when one is exposed to an actual infection with that same bacterial infection, then the host recognizes this as an infection and is able to mount a response. So one is thereby taking away this need for an initial exuberant response to a bug by being introduced to it as an infection for the first time. Next slide, please. So from a historical perspective, the earliest records of vaccination or variolation actually appear in medical historical literature as early as the 16th century. The first disease that humans probably attempted to vaccinate was likely to have been smallpox, and the smallpox vaccine became available in 1796 after work by Edward Jenner. Further work on vaccinations was done by Louis Pasteur. And prior to vaccination, smallpox used to be fatal in a huge percentage of adults, up to 60% and 80% of children. So if we think about it, smallpox was eradicated in 1979. It was officially announced by the World Health Organization to be eradicated on the 8th of May, 1980. So for many younger people growing up now in the 21st century, these stories about the devastation of smallpox and other similar childhood illnesses really only belongs belongs in textbooks, not from any sort of personal experience. If we consider other illnesses which have nearly been eradicated, like polio, which only exists in small pockets of the world in negligible numbers, certainly my parents' generation will be able to report people in their communities that they actually knew with damaged or distorted limbs or lung disease from having had polio. Now in the modern era, we'll be hard pressed to find anyone who knows of people who have suffered from these illnesses. So the point that I'm trying to get to is that the introduction of vaccines and the smallpox vaccine in particular, which I think is perhaps the most famous for eradicating that disease, really is one of the great advancements of modern medicine. Next slide, please. So Edward Jenner, in the development of the smallpox vaccine, had observed that in milkmaids, they developed a condition called cowpox, which they acquired from the cows, and they developed mild forms of rashes. And to him, it was curious that these women never actually or didn't seem to ever acquire smallpox, which in those days in the 1700s was relatively common. So he did some investigations into why this was the case. Next slide, please. And what he initially did in his work to develop the smallpox vaccine was that he took some of the material from the cowpox lesions, the vesicles on the milkmaid's hands, and then inoculated children with this material. After 2 months, the child completely recovered from cowpox, and then on further inoculation with smallpox, the child did not develop smallpox, which was incredibly fascinating back in the 1700s. We can go to the next slide. So images of rashes like these in children are quite easy to find, and this sort of devastation that we see from smallpox and childhood exanthems is something that we hardly ever see these days, even in diseases such as measles and chickenpox, which we still do see in small numbers. It's certainly not as common as smallpox was back then. I found this little article advertising smallpox vaccination very fascinating. So it was submitted by the Department of Health in the US back in the 1800s, and the caption in the middle that stands out: "Why not avail yourself of the certain protection?" And I think this is a question that that in the modern era we are asking ourselves of the COVID vaccine as well. Why not avail yourself of the certain protection? Although we will talk a little bit just now about the kind of protection that one can expect. Next slide, please. And this was from the World Health Organization's official announcement in May 1980, announcing very proudly that smallpox had been eradicated. Next slide. So these are some of the vaccinations that are now very commonly available for in the childhood regimen of vaccination schedules. And we see now that that since smallpox vaccine, there are several others that are available, with the BCG for tuberculosis, polio vaccines, rotavirus, and various combination viruses for DPT being diphtheria, tetanus, pertussis, hepatitis B, hepatitis A, pneumococcal vaccine, meningococcal vaccine, and even chickenpox in some areas can be included on that list. The HPV vaccine, which protects people against cervical cancer, is another one that is also a lot in the media, a very contentious vaccine, but in my opinion, a very important one in preventing cervical cancer. Next slide, please. So coming to the COVID vaccine, so there are various vaccines that are available. So the slide is a little bit inaccurate. The ones that are currently available in this country are the Janssen or the J&J vaccine, which was initially rolled out to healthcare workers in the Oncocare trial, and the Pfizer vaccine that is now being rolled out to various age groups. Currently, the 50 to 59-year age group is open. The 60-plus age group has been open for quite some time now. And I believe that on Thursday, the goalpost is going to be shifted down to the 35-year-olds and over as well. The AstraZeneca and the Moderna vaccines are not currently available in South Africa, but they are available in other parts of the world. Next slide. So a popular question that patients ask me in my clinic is, well, there's all this talk about vaccines and media sort of promotion of vaccines, but are they actually effective? And the simple answer to that is yes, they are effective. But I think one's expectations of the kind of protection and the kind of efficacy from these vaccines needs to also be realistic. So we are not aiming to prevent all infections by vaccinating people. So we aren't preventing the acquisition of infection, but rather trying to afford people milder infections and ones that are more survivable and infections that do not necessarily necessitate admission to hospital and ICU admission and ventilation. And in doing this, we are seeing it already in these populations who have been vaccinated so far, that there are fewer complications from COVID, fewer reports of patients requiring ICU admission and ventilation, and certainly fewer deaths from COVID. Next slide, please. And the next question that we get asked fairly frequently is, are COVID vaccines safe? And again, here I'm going to answer very simply that yes, they are safe. There is risk of allergy to some of the components, which can be a risk in most vaccines, but unless one has a contraindication or an allergy to a particular component of the vaccine, there are very few other contraindications or reasons why people should not be vaccinated. There is a lot of concern about the risk of thromboembolic disease, which has been spoken about in the media. It is there, it is present, but is extremely low. There does also seem to be a difference between vaccines in that some appear to be more or less likely to cause thromboembolic disease. But again, here, I would say that unless a person has a particular risk in this area, in which case this is also, again, not an absolute contraindication, one should then consider discussing this with your oncologist or with your general practitioner. Another concern from patients that I hear a lot is that, well, I'm going to get the COVID vaccine. Am I going to get this COVID infection from this vaccination? Well, as we spoke about in the concepts, in the basic concepts of how vaccines work, we do expect and we want the vaccine to stimulate the immune system. And in doing this, one can experience some symptoms of mild infection. There have been some reports of individuals getting very high fevers and lassitude and fatigue from the vaccine. But certainly, we do not expect a person to require hospital admission or to develop grave illness from the vaccine. Further to that, these symptoms or side effects of the vaccine, if one wants to call them that, are usually relatively short-lived and easily dealt with simple paracetamol and some rest for a few days before people are back on their feet again. But having said that, as we are seeing more and more people actually getting vaccinated, we are being reassured in that very few people are actually developing any of these symptoms or complications. Next slide, please. Can oncology patients be vaccinated? And again, the answer is a resounding yes. There are a few patients in oncology where we do need to exercise caution, and it is important to also point out that patients with active cancer and those on immunosuppressive therapies, which includes chemotherapies, but also long-term or repeated steroid use, can have a decreased potential to mount an antibody response. But there again, this would also be a reason to offer these patients the protection of the vaccine. So while we do expect that some of them might have less of an immune response, there is an imperative to protect these patients because we do consider them to be a vulnerable population being immunosuppressed from their cancer and from their treatment. Most patients are eligible except in exceptional circumstances, which we will touch on in a moment. Next slide, please. So I've picked the American Society of Clinical Oncology's guideline, or an excerpt from their guidelines, the American Society being referred to as ASCO among the oncological community. But certainly other organizations overseas and the local authorities as well are adopting similar sorts of guidelines, which essentially communicate to us that patients with cancer may and possibly should be offered vaccination, provided there are no contraindications to elements of the vaccine. And the vaccine recipients should be counseled that we are not very certain right now about the safety profile in immunocompromised individuals, and there is a potential for reduced immune protection. But I think this also comes from the fact that this is a relatively new disease to us, and therefore also relatively new vaccination. So over time, we will acquire this information, more long-term data, but based on the fact that we are in the middle of a pandemic, we are seeing that the vaccination does offer protection and therefore should be offered. Patients receiving active oncology treatment may be offered the vaccination, and cancer survivors may also be offered the vaccination. It's really only those patients who have contraindications to components that should not be offered it. Next slide, please. In terms of timing of vaccinations, the National Comprehensive Cancer Network, which is again another American-based organization, which collates data from various studies and puts them together in a guideline. They have put out a statement saying that patients receiving hematopoietic cell transplantation, so in other words, patients getting stem cell transplants, should wait for at least 3 months after the transplant before they get vaccinated. And the rationale behind this is that a stem cell transplant and all the treatments that are required around the transplant are extremely immunosuppressive. So in those patients who have very little immunity, we do have concern that the vaccine might induce more severe symptoms, and also that these patients will not then mount a sufficient immune response to the vaccine, which is more likely to occur if they wait a few weeks or at least 3 months after that transplant has been completed and they're fully recovered. In a similar vein, patients on intensive chemotherapy for acute leukemias should at least wait until full neutrophil recovery, which can take a bit longer than patients who are on chemotherapy for solid tumors, in which case those chemotherapy regimens tend to be a lot less immunosuppressive than those used for acute leukemias. Patients undergoing major surgery should wait for at least a few days before vaccination, so not too much of an impact on from major surgery to vaccine timing. And very importantly, that unless one of these special circumstances occur, which are not very common in oncology, all the other oncology patients may be vaccinated as soon as vaccines are available. And I think that's a very important statement, because right now with vaccines becoming available, patients are very anxious. Should they have their vaccines? When should they have their vaccines? And the advice that we are giving as an oncology body is to please take it as soon as they are being offered the vaccine, because there is a great sense of urgency to offer patients protection. Emmanuel, was that the last slide?
Yes, it was.
Okay, all right. I think I'm going to end there. I think I've spoken quite a lot. I'm happy to take questions afterwards, and we'll move on to the next part of the talk.
Thank you, Dr. David, for an insightful presentation. Our next speaker is Dr. Zainab Mohamed, who attained her MBCHB at the University of Cape Town in 1992 and her MMed in radiation oncology at the University of Stellenbosch in 2004. Her career as a clinical and radiation oncologist commenced at Groote Schuur Hospital in 2005, and she is presently the head of clinical unit and a senior lecturer at the University of Cape Town. She runs the lymphoma and Kaposi sarcoma clinics and provides radiotherapy services to clinical hematology. Her research interests include HIV-associated malignancies and lymphomas. She has special interest in palliative care and is a co-facilitator on an online palliative care course offered to oncologists by the University of Cape Town. She is a member of the University of Cape Town Human Research Ethics Committee and Vice President in South Africa for AOTEC. Thank you for availing yourself for this afternoon, and we're looking forward to your presentation. So over to Dr. Mohamed.
Thank you very much for that introduction. I was hoping you wouldn't say when I graduated. It's quite a long time ago. Thank you very much to CANSA for putting together this webinar. I think it's incredibly important. It's really, really opportune. Yeah, I'm very, very happy to be participating. Thanks, Ria, for that very good introduction into vaccines, for a lovely sort of stroll through history, and just to show how vaccines have actually changed our lives and how I hope it's going to change our lives again going forward. So let me get my presentation on. Okay, fantastic. All right. So I'm sure lots of you had a busy sporting weekend. It was quite exciting. We had football, we had tennis. And for me, and I don't know if everyone else that might be listening, the most strange thing to see was so many people in a stadium, more than 20,000 people, not wearing masks, not socially distancing. I mean, what's happened? Don't we still have COVID around? How could that be possible? And especially in a country like the UK, and as you can see there, the UK has still got a lot of COVID. The Delta variant has now affected the UK. I mean, 31,000 cases. I think that was on the 12th of July, yesterday, 31,000 cases. But only 26 deaths. So that tells you something's going on here. What's different now in these countries that they can finally open up? Well, firstly, with these sporting events, it's very strict. The entry is very strict. You've got to either be vaccinated or you've got to show proof of a negative COVID test. But look, in the UK, 65% of the population have actually had their second dose, are fully vaccinated. So they could feel confident to actually put up such huge sporting events and not worry that it's going to end with a lot of people sick and in hospital. And in fact, the AstraZeneca scientists that were involved in AstraZeneca work got a spot in the royal box at Wimbledon and were applauded by the crowd. But at the moment in South Africa, we are dealing with a third wave. And from my side at Groote Schuur Hospital, it's really impacting because at Groote Schuur Hospital, we are all drawn into to manage COVID. And we've been opening wards. We've been opening one ward every week. And in fact, now we need to open, we already opened one ward on Monday, and we look like we need to open another ward because our admissions are just going up and up and up. Our ICU is full. So it's really getting bad here in the Western Cape. Even the private hospitals are sending patients to us. But how does it affect cancer patients? How does COVID affect cancer patients? And it's more than just you can get sick, you can get COVID, you can die of COVID. It affects cancer services in many different ways. It affects cancer screening. So people aren't able to go for their routine mammograms or routine colonoscopies because the hospital is full, because all of these have been postponed because you want social distancing. You don't want too many people in a space at a time. It's affected the diagnosis. So a lot of patients haven't been able to go to their GPs or to the primary healthcare facilities, or secondary level services haven't been provided because there's just no space. We've just been overrun by COVID. Imaging, biopsies, all other investigations, there's limited access. And then the treatment, our surgical lists have been cut. We only have 10 surgical lists now. We're actually trying to maintain our surgical lists this time around. In the first wave, they were all cancelled. In the second wave, it was during the Christmas period, so we were already a little bit low. But this time we're really trying to maintain some surgical lists because we really don't want these patients to wait too long for their operations. But as I said, we're opening more and more hospital beds for COVID. So it looks like it's going to be affected as we continue upwards with our surge here. Staff shortages. And interestingly, this was a huge problem in the second wave because of the South African variant. We had a lot of patients, a lot of staff members affected. And that really impacted on the type of service that we could deliver. It seems a lot better this time around. The people that have been sick, the vaccinated people that have been sick, have had no issues, have managed to return to work with minimal sequelae. The cancer services, also our follow-up services have been affected, and we've tried telephone consultations for patients, but this just really is not the same as seeing someone face-to-face. And then another huge impact of COVID was the effect on palliative care. So the hospices need negative COVID tests before admitting patients, but a lot of patients then ended up requiring palliative care or dying in the hospitals, not being able to see family. So it's really been severely affected by COVID. Also, the home visits and the outpatient palliative care facilities have been affected. This study was published towards the end of last year, and they were looking at a whole lot of Medicare patients in the US. And these patients are normally screened for cancer. And they were just looking at this graph. This is how it changed during that first wave in the US. All their screening services, mammograms, colon screening, lung screening, prostate screening, all of those, when compared to the 2019 figures, had reduced by sometimes up to 85% here during the peak of their first wave. Not only screening, because you can skip your screening, you don't always pick up a cancer on your screening, but what about diagnoses? So the number of biopsies decreased. And what about your treatment? The number of surgeries drastically decreased. And this is only one study conducted with a cohort of about 6 million Medicare clients in the US. And these are elderly patients. So for us in South Africa, it's been very challenging for patients. Very difficult to access medical care. I remember during the first wave, the patients didn't know how to get here. There was no transport, the taxis weren't running, the trains weren't running. And when the taxis eventually did start running again, there was the fear of coming to hospital in a taxi full of people and the risks of COVID. So it was really difficult. Also, our patients that came from George and from the rural areas, they needed COVID tests before they could travel in the ambulance, and those that were positive. In fact, we've got at the moment someone with melanoma who's positive, and he can't get home, even though he's fine. He can't get home because the ambulance can't take him. They won't take him until he's out of his isolation period. And then economic. Patients lost their jobs. They couldn't actually afford to get to hospital. It was more important to get food for the family than to have to actually come to hospital for your treatments. Routine appointments were cancelled. And we tried to rebook, but a lot of patients would just fall through the cracks because a lot of these appointments just didn't happen or just weren't done again, especially in a big hospital like ours. We really tried our best though not to let this happen. And then telemedicine, really it's not ideal for those who are elderly, those who are vulnerable. And at the moment now, and with each successive wave, the primary and secondary hospitals are overrun with COVID-19. There's a huge risk of exposure to COVID-19 for these vulnerable cancer patients. And there's a huge or massive fear of contracting COVID-19. And a lot of our patients who didn't present during the beginning of last year actually presented later on with very advanced cancers. And what treatment delays also cause is stage migration. So in other words, when somebody comes to you or when someone is maybe diagnosed, they might be in early stage, and by the time they actually get their treatment, they've advanced disease. So we've seen a lot of that happening as well. We've had to change the way we treat our cancer patients. So we've had recommendations for shortening treatment courses, for concentrating on radical patients. Those are patients that we actually want to cure, and not so much on those that we're just palliating. For the palliation, we would give really short courses of radiotherapy. We would maybe not give chemotherapy for those patients, only for the radical patients. And for the radical patients, we try to switch to oral chemotherapy drugs where we could. And this is how it affected us. So we've got some data here from 2007, and this is just looking at the total numbers And as you can see, the total numbers have increased through the years. And in 2019, we saw over 3,000 new patients. But what happened in 2020? We only saw about just under 2,500. What happened to that 500 plus patients? Because we were seeing increasing year on year. What has happened to those people? Where are they? Have they been diagnosed? What is going on? I think we're going to have a large backlog and a lot of cancer patients presenting late in the near future. And just looking at it clinic by clinic, the breast cancer clinic, which was our biggest growing clinic, can you see how fast it's grown through the years? A sudden drop in breast cancer, a drop in the urology clinic, in the bronchus clinic. So I think this is really something that we're going to have to do a lot of catch up on. Just looking at surgery, new breast cancers diagnosed had decreased between 2019 and 2020, and breast cancer surgeries also decreased. In fact, in some months we were doing half the surgeries that we had done the year before. This is a study that was done in the UK, where they were looking, and they've got lots of data there because they've got the NHS and they can look, and they're looking at deaths, looking from January 2020 right through to March, when things started hotting up in the UK. And if you look at this graph, you can see the blue are the cancer deaths, which look like they haven't really changed that much relative to the others. The red are the COVID deaths and the yellow are the non-COVID deaths. But as you can see, in comparison to what was seen before, cancer deaths has also increased along with your COVID deaths and your non-COVID deaths. So there were a lot of patients that were cancer patients that were affected by COVID. And then there's the collateral damage. The other things that we don't think about, the psychosocial damage, because patients are alone, they can't get visitors. And during the first wave, we were very strict. I think we learned, and we were a little less strict during the second wave, but the saddest thing is to have patients die alone in hospital, to not be able to have their family there to sit with them. Yeah, so there were a lot of people that actually didn't get closure, that lost loved ones. We couldn't do proper family counseling face to face. It's very hard to phone someone and to tell them your mother is not doing well and we don't expect her to survive the day. That was really, really tough. And then also patients really struggling with unemployment, with not having food to eat. That was really very challenging for everyone involved. We really tried to help where we could. There's lots of anxiety around. Staff are anxious, patients are anxious, family are anxious. And then for our cancer patients, when they've presented with fever or any respiratory tract infections, they automatically became PUIs. That's what we call persons under investigation. They were automatically investigated for COVID. And that was a problem with patients with what we call neutropenic sepsis. And for a lot of you cancer patients, you probably know what I'm talking about. If you come in with a fever, that might be due to your chemo that's caused your blood counts to drop and you now have an infection. You need to be treated urgently. You need to get antibiotics. You need to be treated properly by an oncologist. And what happened was they had the COVID test and they had to wait for the results for the COVID test before they could actually be treated properly. Another bits of information that I got from just looking at the UK figures and at articles published in the UK was that they found that the lung cancer numbers went down dramatically. And in part, that was because patients with coughs were asked to stay home. So a lot of lung cancers were missed because people just didn't go to hospital because they didn't know, what do I have? Do I have COVID? Do I need to stay home? And then we've had a lot of patients contracting COVID, and that was challenging. Patients can get COVID and be well, but it still delays their treatment, their cancer treatment, but they can also get severe illness, and especially if they are immunocompromised due to their blood counts being low, due to their cancer. And in fact, I actually lost 2 patients in the past 2 weeks due to COVID, cancer patients. The one had only just started his treatment. He was elderly. The other one actually had a complete what we call a complete metabolic response to a chemo. She had done really, really well. But then she came in with COVID, and both of them contracted it from families. And at present, I have 2 more patients that have COVID, and one has now been admitted to the ward. So it's extremely challenging to manage your cancer patients with COVID. And then one thing that people don't know is that COVID also meant that there were problems with supply issue with drug supplies, especially oncology drugs. So the loss and the bereavement, and I'm not only talking about patients and their families, I'm also talking about staff, doctors, nurses, everyone. For everyone, it's been a really tough time. So yeah, I was listening to a talk, and this Professor Barry Bloom was speaking about just looking at it from a public health perspective, looking at COVID. And the one thing he said, and I thought, oh, this was a quotable quote: the key ingredient in all vaccines is trust. And just worldwide, for those people in South Africa who are scared to get vaccines, worldwide 3.42 billion have had at least one jab as at the 10th of July 2021. So you can't say that this is an untested technology or new technology or drug that hasn't been tested. 940 million are fully vaccinated, and I'm sure that number is a lot higher now because they are administering 29 million vaccines daily. The country that is well ahead is Canada. Nearly 70% of their population's already been vaccinated. Just to compare that to India, which has a huge population where they've just had a devastating second wave, 22% vaccinated. In low-income countries, only 1%. In South Africa, 2.3% are fully vaccinated. But I'm hoping that with all the with this webinar and with all of you going out there and trying to convince everyone to be vaccinated, that we get those numbers to go up very quickly.
Dr. Mohammed, can
yes,
I
my time.
Yes, we have less than 1 minute remaining.
Okay, so I was going to talk about variants, but I don't think there's enough time to talk about variants. So if anyone wants to know anything about variants, we can discuss that later on. Just to say that at the moment, the Delta variant is the one that's predominating in South Africa, and that's causing all the issues that we have at the moment. And then I was going to talk about conspiracy theories and rumors around vaccines. And we know there's a lot of that around. There was a study published earlier this year where they looked at where these rumors originate. And as you can see, the countries, the purple, the dark purple, India and the US, and then Brazil, it seems that the countries that were worse affected by COVID had the most rumors about vaccines, the most conspiracy theories originated from these countries. And I just want to read this out of the article. The author said, whether the person believes the misinformation or not is dependent on the individual's level of health literacy and their risk perceptions. So we've heard that there's a lot of young people that are vaccine hesitant because their perception is that their risk is low. Health literacy really has to do with how much education you have, how much you understand about the human body and how it works. But I think this is really something that people need to stop sharing. And is that it? Do I have to stop now? Okay. Okay,
Thank you so much.
That is it.
Yes, Dr. Mohammed.
Yeah. So thank
you so much for an informative presentation, and also telling us about the impact of COVID on cancer services, and also the impact of COVID on the psychosocial and the economic factors and patients and cancer patients. So now we're rounding up with our last speaker. It is Dr. Vicki Pinkney-Atkinson, A strong advocate for people living with non-communicable diseases, she is the CEO of the South African Non-Communicable Disease Alliance, in which capacity she has served since its formation in 2013. Vicki was born with a NCD, psoriasis, and now lives with around 20 NCD conditions. She is the survivor of multiple near-death NCD experiences, which shaped her NCDs and health activism. Today, she advocates for NCD's equity and policy coherence in South Africa. She has over 50 years of work experience in the health sector, allowing her 360-degree perspective of stakeholders and spaces that stretch Soweto in the 1970s and rural apartheid homelands to continental and global forays. Today, she enjoys the reach and safety that the internet provides. So join me in welcoming Vicki for her presentation.
Hi there, thanks so much, Dr. Brenda and the previous speakers, Ria and Zainab, that you've all contributed to what I'm going to say. So you know that I'm a croc. You know that I've got lots of illnesses. I haven't had cancer, touch wood, but it's always there, as you know. But I've had methotrexate as treatment for my illnesses because I have an autoimmune condition. And that nearly has been responsible for most of my near-death experiences because it flattened my immune system and I got wild and wonderful infections and nearly died through AIDS-like infection, encephalitis, meningitis. So that's the bottled story of where I am and why I'm here. I am a healthcare professional. However, that pales insignificant when I have to take on the government to fight for our health rights. I am so tired of doing it, but it is my job now to do it. And I'm here to reassure you that we're not sitting back and doing nothing. I think we had from Zainab saying that trust is important. Well, for vaccination to work. I'm afraid that in South Africa, we have very poor trust in our government because it has not been inclusive, it has not been transparent in no way to people living with non-communicable diseases. Not now and not for the last 10 years. Whenever we ask about non-communicable diseases, including cancer, there is deathly silence. And that is why we in the South African NCD Alliance, with our many 100 allies, including cancer, have a case at the Human Rights Commission for before COVID, during COVID, and after COVID, for a failure of the government to give us equitable healthcare for non-communicable diseases. And this is particularly true in the public sector. And I, partly as a response as being an activist, and the other part is that I've been old and sick for so long, I am a person who uses the public sector. I haven't been able to get there since the beginning of COVID. And so it's kind of moot. I just have to buy it and stay safe. I also use insulin. So as Zainab will know that it's really ridiculous me trying to get to Groote Schuur to get my insulin because I can't get it at clinic, you know, and I have to take insulin every day for the rest of my life. And so we all live in these little stories. So I'm telling you a political story, and I hope somebody will give me a flash to say that I'm 5 minutes and over speaking my time. So I'm telling you a political story about a pandemic and non-communicable diseases. Non-communicable diseases are the biggest number of diseases in our country, illnesses, conditions, whatever you want to call them. They involve people with disabilities. It's a huge group of, it is the #1 and the biggest cause of death in our country. However, it is the most underserved. Cancer is a big part of that. We, with things like diabetes, we don't even get in for screening. It's just the same everywhere. And So non-communicable diseases, often you don't get one non-communicable disease, you have several at the same time. And our system is only trained to look at one illness at a time, HIV or TB. Our health system has only focused on HIV and TB as health conditions and funded those conditions since 2007. And nothing has changed in that period of time. And so here, and during COVID, it was very clear, number one, I have to say, is that it's been very clear for a very long time, 100 years, that we were due a pandemic. And so let's not pretend that the pandemic is a surprise. It was coming, it was expected, and if anybody was watching the international news like I was in December, you would have known that the pandemic was here. Because if you looked at what was going on in Wuhan, China, you weren't. And I was due to go to a global conference out of the country in a very big hub. And I knew that people would be flying in and flying out, and I would not be safe. And so in early January, I was taking care of myself and putting masks and buying nasal creams and doing all the rest because I've had a suppressed immune system. I'm terrified of getting another infection and dying. I just want to go quick. I don't want to go through this infection stuff again. And so it wasn't a surprise. And the early statistics coming out of Wuhan were very clear that deaths were happening in older people, but there was a long list of comorbidities that were there already: diabetes, hypertension, cardiovascular disease. There wasn't ever a mention of TB, and there was never a mention of HIV, which is not surprising, it being China and not Africa. So anyhow, now let's fast forward right through all of this time. From the beginning, we have been asking that comorbidities, what are the comorbidities that are at risk? Because the government did not, in none of its discussions, did it ever mention, or very seldom mentioned, that non-communicable diseases were the biggest group of comorbidities that required attention. Never. They even, so that we asked and asked and asked. All we got was that it's HIV, TB, and even at one stage malaria, which is unlikely in the extreme. And so very late did they start talking about diabetes. Obesity is a major comorbidity. Why was that? Because our health system has got no data and no information about non-communicable diseases. And that's the reason we have neglected NCDs. We don't know how many people have diabetes. We don't know how many people have hypertension. And if you're in the public sector, you're not going to necessarily, those figures are even worse. If you're in medical aid, they will probably know about it and you'll probably get the treatment, but not for 85% of the people in our country. So that's really where we ended up with. And right until this day, the recognition and the acknowledgement that NCDs are a major morbidity has not come clearly enough from the government. And now this is where I'm going to switch to my slide, and then I'll. So you know, it wasn't a surprise that we were getting vaccinations either. And what I'm being very outspoken is, and I'm speaking for myself as a person living with NCDs, is that there is no shock in everything that happened, you know, that we have gone through in this last period of time. And what I'm looking at here is the phase 2 of the vaccination, which we asked very clearly time and time again, and we were completely ignored again throughout this whole 18-month period for NCDs. Phase 2 was where there was supposed to be about 18 million people vaccinated. The only group in that phase 2 of the rollout of vaccination, which is mysteriously changed dramatically without a proper statement, without any discussion, without any public policy, The only group in there that they can actually measure in South Africa at this time without making political judgments is persons over the age of 60. And that is why we're stuck with this whole stuff about people and going by age group, is because our system has systematically failed to take care of the people that are most vulnerable. And if you think cancer care is difficult, I agree it is. But nobody with an NCD in this country who uses a public service can get away without severe and dire hardship. We ran a helpline, a diabetes helpline, and we still do, and it's horrendous. So let's say here we know that if you're over the age, there were 5.5 million people in there. You can actually measure those people down to the district in which they live. It's not a surprise. One of the people on this call with me, Peter Hers, and I worked together on mapping that and actually predicting which provinces would be the most burdensome. Because we say that age adds to comorbidities. Is it age on its own? We don't know. Although there are some studies, if we had better stats, maybe we would see it. But it was very clear that the Eastern Cape had the highest dependency ratio, and then Western Cape. So none of this is a surprise. And why are we still struggling to get our old people to be vaccinated? I'm one of those old people, and I'm fully vaccinated. I'm very blessed. One in the private sector and one at Alex Clinic. Essential workers is a judgment call. We have seen globally, when you map out which occupations are at greater risk, teachers and teaching do not come off high. But it may be that we're a developing country, and maybe there are others. Caregivers. So what I'm saying, it's a political decision. Persons in congregate settings have never been clearly defined, and nor are they clear, except perhaps prisoners. You know, that one we're getting right. When it comes to persons with comorbidities, forget it. They have never defined what a comorbidity is because it's impossible. It is not true that nowhere in the world, that's what the government is saying, nowhere in the world has anybody done it by comorbidity. It's not true. There are countries like Israel who can actually tell you to the nth degree if you've got a good record system in the public, which of course we don't have. And so that's how I am saying is that group, those are 8 million. We are the biggest group, the people with comorbidities. The only people that we're talking about with comorbidities are those usually who are poorly controlled. In the public sector, most people never get diagnosed with their hypertension or treated properly or their diabetes. And that's why we've got a human rights case against the government. We're sick of it. And so what we're saying is, please, let's move ahead. Let's find a way of holding our government to account, but taking care of our most vulnerable people, people with disabilities, people who are caregivers. The cries for help are there and big and loud, and it is time that we make our government respond to we, the people. That's kind of where I'm at. And I'm trying to reassure you that we're not done. We have a case with the Human Rights Commission. And again, that we're informed that the government, the health minister, the last health minister refused to answer the questions around COVID to the Human Rights Commission. And so that is the state of the play when it comes to NCDs, to us and to we the people. We have to get our voice and we have to speak. Thank you so much. I'm sorry if I've given a wild rant, but know that you are loved and we're fighting in your corner. Thank you.
Thank you so much, Dr. Vicki. And from my side, I mean, I'm passionate about issues of justice and equitable access to care, and at this present moment, specifically to vaccines. And yes, definitely appreciating the work that you're doing. And thank you for the presentation. So right now, as mentioned earlier on, we'll move to the Q&A session. And it's quite interesting that you've received a high number of questions. And so we'll try and see if we can address all of them during this period. And if not, the CANSA team will advise on how those will be carried forward. So I'll start with the first question. How long does the vaccine last? Will we have to continue having a vaccine like the flu vaccine? I will ask Dr. David to respond to this question.
Thank you, Brenda. So I think it is likely that we are going to require boosters in the future. The exact time intervals, depending on what vaccine you originally had, haven't really been defined yet. But I think if one wants to base this scientifically, it is possible to get your antibodies tested. Now, how practical this is for everyone to do that is another question altogether, because this will obviously put a huge burden on the health system. But for those of us, who've had access to private care and who are able to pay, it's been quite interesting. Among some of the doctors that I know, doing your antibodies every couple of weeks or months, it does seem that the antibodies do last for a long time. This is all very anecdotal information. I can't say that this can be extrapolated in any way. It's just a curiosity to me rather than anything else. But I think that in reality, one must expect that, similar to the flu vaccine, that we are going to need boosters in future, except that we aren't really clear yet exactly at what time intervals, and then which groups are at the highest risk again, and are there different intervals for different groups of people.
Thank you. If you have had COVID-19, how long should you wait before getting vaccinated? Dr. David? If you don't mind responding to this question.
Oh. Okay, so in terms of the timing for vaccines, there are certain delays that are advisable after getting active COVID infection, and also after between your flu vaccines as well and other vaccinations. Some of this advice is also based, especially with other vaccines, is based on the fact that one may react to another vaccine and then not know which one is actually the causative agent if one has a problem after vaccination. So I think after flu vaccination or before a flu vaccination, there should be at least about a 3 to 4 week gap between that and the COVID vaccine. After an active COVID infection, one should wait at least a few weeks, at least up to 6 weeks before having the COVID vaccine, provided that you have fully recovered from that infection and have no residual problems or complications thereafter. I think if one has had a complicated course with COVID, it is rather best to discuss this with your treating doctor at the time.
Thank you. And the next question is for Dr. Mohammed. If you are about to start radiation, is it fine to receive the vaccine?
Yes, there's absolutely no contraindication between having radiotherapy and receiving the vaccine. In fact, I would advise anyone who's going to visit a hospital on a daily basis to actually be vaccinated, because you don't know what you can pick up in the hospital. Thanks.
Thank you. The next question is on contraindications for specific vaccines. Someone wants to know, what are those contraindications? And she or he also mentions that he had a pulmonary embolism during chemo. So I will ask Dr. Ria, maybe followed by Dr. David Dr. David followed by Dr. Mohammed to respond to that question.
Okay, so with respect to contraindications, it becomes a bit technical because one has to go through all the components of the vaccine. And while we were having the discussion, because I could see the questions coming up, I did have a quick look at all of these things, and they become components like acetic acid, sucrose, various other sort of adjuvants and things that they mixed into the vaccine. So similarly, for your childhood regimen of vaccines, if one has an egg allergy, there are certain vaccines that are cultured on an egg-based medium that child cannot have. So it's those sort of basic principles that one needs to abide by. With respect to thromboembolic disease, I think this needs to be individualized. The risk of thromboembolic disease directly from the vaccine is extremely low. And in my humble opinion, I think possibly a little bit inflated by the media. If one has had a pulmonary thromboembolic disease previously, one would imagine that this particular individual is probably on full anticoagulation, and in which case I certainly would advise and encourage them to have their vaccination. I don't know if Zainab has anything to add.
No, I don't have anything really to add to it. I think that there are lots of questions coming up on the chat, and a lot of it are people's own personal scenarios. I have breast cancer, I'm on this, I had that. And for all of these patients that are on the chat, please, you need your vaccine. It doesn't interfere with your cancer treatment at all. The only ones are the ones that Ria spoke about that might be coming out of a stem cell transplant, that might be getting chemotherapy for very intensive chemotherapy for leukemias, those patients, because they might not be able to mount a response to the immune system might not be able to mount a response to the vaccine. So the vaccine actually doesn't cause more side effects, but actually doesn't work. There's also been another patients on rituximab. There might be a query over whether they actually mount a proper immune response to the vaccine, but I still wouldn't discourage my patients from taking the vaccine. Everyone should have the vaccine. The chances of contracting COVID and dying of COVID are a lot worse. I see there's the ivermectin question. I've prepared slides for that. I don't know if we have time to look at it. Up to you, Brenda.
Yes. Okay. Now that you've brought up the ivermectin, I think maybe it's just responding to the question that is on the chat. If you don't mind, Dr. Mohamed, before we continue with the other questions.
Yes, are you talking about the ivermectin question?
Yes, you can share your slides. Yes, please do. Thank you.
You can share slides, yes. Whilst you're looking for your slides, I'm just going to pose a question to Dr. Vicki, because today she's wearing a patient's hat, and we have experts here. Are there any questions, concerns, or fears from the patient's perspective that you think we need to address or unpack in this session?
Sorry. I think we're addressing some of it, but I think it's incredibly complicated when you start dealing with a person living with a non-communicable disease who lives in a family with caregivers. And those are the kind of questions I see coming up. It doesn't even matter if it's if you've got a comorbidity, and most comorbidities arise out of people not having controlled illness. Like obesity on its own is an uncontrolled illness, and HIV that's not controlled. So when you've got those and you've got a family and a caregiver system, some of us are very dependent on our caregivers, and there is such anxiety around that in groups, because what do I do if I can't get up and be cared for in the morning? You know, it goes for mental health patients. And so I think that's what I would like to be asking. How are we going to resolve the issues, whether it's shielding in a community, or how do we resolve the issues where our caregivers are not getting vaccinated too? And every time they go out, they can bring us back and make us sick. So how is that?
Thank you. You're raising an important question. I'm not sure if my colleagues want to respond to that, but I know that Lucy from CANSA is listening, and she is in touch with policymakers, and some of the conversations and the points that are being raised here, I'm sure she will take them forward to the relevant parties.
Yes, thank you, Brenda. I will certainly do that. We've put our email address there. And I think people are quite keen to hear what Dr. Mohamed has to say about ivermectin. It is on the list of questions.
Thank you. She can start sharing her slides.
Okay. So I knew that question would come up because there's been a lot, it's been in the news, and it seems that everyone actually a lot of the patients that we're admitting now, that we're seeing now with COVID, have had some sort of access to ivermectin. So just, it's an old drug. It's a broad spectrum anti-parasitic drug. In other words, it acts against parasites. There's a disease called onchocerciasis or river blindness. There's some intestinal worms, even things like scabies. So that's really what it's registered for in countries like the US. In South Africa, it's also been used for animal parasitic infections. And what they did when COVID actually came along was they were looking for something to treat it. So they tried a whole range of old drugs in the lab, putting them against COVID-19 to see if there's any activity. And it was actually found to be active against COVID-19 in the lab. But the problem is that the dose that you use in the lab to kill the COVID-19, if you had to translate that to the amount that you need in a human being, it's probably have to be 9 times the recommended dose, or the safe recommended dose of ivermectin in patients. And there are lots of small studies, really small studies, that claim efficacy, but these studies are not that well done. They're not peer-reviewed. They're not published. Some of them are just preprint publishing. So, you know, the evidence is not there that it is actually effective in the prevention or the treatment of mild to moderate COVID-19. And I have 2 large studies that actually do not show a benefit over placebo. And I'm actually going to show you those studies. But just, I had to come to terms with ivermectin because there's so much hype about this. I had to come to terms with the fact that, you know what, if it does no harm, people take it because the placebo effect is an amazing thing. And, you know, maybe it'll make them feel better, and that's okay. It's safe at the recommended doses, but it can interact with blood thinners. And there are severe adverse effects like seizures and ataxia that have been reported with normal doses, but with overdoses. And the problem is the overdose, because people don't actually know how much to take, and they're taking horse ivermectin and whatever, can result in nausea, vomiting, diarrhea, low blood pressure, allergic reactions, coma, and even death. So it's not recommended for treatment of COVID-19 by the FDA or the World Health Organization. And the SAPRA has stated that there's not sufficient scientific evidence to support the use of ivermectin in the prevention or treatment of COVID-19. And these are the 2 studies. Now, I know that not everyone is scientific and not everyone has looked at studies and articles, but these are the 2 largest studies. And this one, they were looking at using ivermectin to prevent hospitalization. So when patients were diagnosed with COVID-19, they were put on either ivermectin or a placebo, and they wouldn't know which one they're taking. And if you look at this graph here, you'll see, and this is for mild to moderate COVID-19, there was actually no difference in hospitalization between the ones that got ivermectin and the ones that got placebo. And these are 500 participants on this study. And then the other bigger study, where they had about 400 participants, they looked at ivermectin, taking ivermectin, how long does it take to actually resolve your COVID-19 symptoms? And if you look at this graph here, you can also see they kind of one overlies the other, so there's really not much difference. And I just want to compare this to, so before I get there, I just also wanted to so we know it's not registered in South Africa. But you can get it under a special dispensation, compassionate release. But the problem is, what are you actually getting? So in the South African Medical Journal, they've actually analyzed 7 ivermectin formulations available in South Africa. And for those of you that are taking it, you might want to let you know which one you're on. Iver 112, Biomec, there's all these different ones. And they analyzed it to see what is in it. And all of them had ivermectin in, so that's one good thing. But some of them, and particularly the 4 that come from India, in fact, the 4 that come from India, the one from Bangladesh is fine, the South African ones are fine, that are compounded by pharmacists in the pharmacy. But the ones that come from India contain other drugs as well, paracetamol, diclofenac. So if you are allergic to, let's say, Voltaren, and you take this drug, you might react to it. You might get sick from it. You might even die from it if you have an allergy to any of these drugs, but you won't know because it doesn't occur on any packet insert. And then I see here, this one, ivermectin, number B, IVA 112 has a drug called telmisartan. I know that drug. That's a drug I take for hypertension. So it's weird. What is it doing in ivermectin? So just to compare those graphs, when you saw those graphs and you saw hardly any difference between placebo and ivermectin, this is the Johnson & Johnson ensemble study where they look at moderate to severe or critical cases of COVID-19 and then severe to critical cases of COVID-19. And can you see this huge gap here? So this is the vaccine, that's the placebo, and as the line goes up, that's more people with moderate to severe COVID-19. And can you see that the vaccine does prevent moderate to severe COVID-19? That's all I have to say about ivermectin. Thanks.
Thank you so much for that important information. And we all know that, ivermectin issues have been topical in relation to the treatment or the prevention of COVID-19. And thank you for sharing that information. And I think it's also important, to note that there's a lot of information that is being circulated on social media and other media platforms. So I'm not sure if Dr. Zainab wants to say something regarding misinformation that is circulating on different social media platforms.
So I've actually noticed now with more and more news reports coming through and more information on the international media about how the unvaccinated are getting sick and dying. And this was the CDC report in the US, and it's available. It's on, the unvaccinated are the ones that are dying of COVID-19, not the vaccinated. I think people are going to get a clearer picture of things when they look at the whole world. And I think I'm hoping that all of these conspiracy rumors and all these weird things about 5G and there's some really weird things. Aeroplanes distributing COVID-19 over different, it's just unfathomable how many of these weird conspiracy theories are out there. People really have to check. They have to do their research and proper research. And anyone who's gone on to, if you actually research COVID-19 vaccines and cancer, you'll get proper, reputable information now because it's out there. That knowledge is out there. I'm hoping that it's going to settle down now as people can see the good effect that vaccination is having in certain countries where they can actually open the country again. We can't do that yet. We want to return to normal. So hopefully we will be able to return to normal if we're all vaccinated.
Thanks again for that. I think just to reiterate, it's important that information is accessed from credible sources like the Department of Health, the World Health Organization, and some other hospital groups, and some of the information that is being provided by private health funders like medical aid, etc. So it's quite important to ensure that the source of information is credible. We have quite a lot of questions, so I'm just going to take a few. And I won't go to the details, but there's just common themes in these questions. So I'm just going to raise one question with Dr. Zainab again. The question related to patients with low white cell count and low neutrophil count, if it's safe for them to receive COVID vaccine.
Okay, so I think it's safe from a side effect profile, but my concern would be that your body with your white cell count that's low won't be able to mount the immune response. So when all of us got our Johnson & Johnson vaccines and people got so sick, it's because the vaccine is working. You want that to happen. You want to feel like you've got a bit of flu or something. So my worry with low neutrophil counts is that you're actually not able to mount a proper response to the vaccine. So I would advise my patients to take your vaccination, to time it either just before you're going to get your chemo, in which case your neutrophil count should be fine, or just after, before it starts dropping. So just to get the timing right, not to take your vaccine when it's at its lowest. And for most of you on chemo, you know that's 1 to 2 weeks after your chemo. Depending on the type of chemo, it can be quite low. So try to get the timing right.
Okay. Great, thank you. And I'm assuming that some of our delegates are not vaccinated yet. And I'm just going to ask Dr. Vicki, because she is fully vaccinated, maybe just to share her experience related to vaccination and if she experienced any side effects. And if yes, how did she manage them?
Thank you for the question. I tell you what, if I had been immune suppressed like I was when I was on methotrexate therapy, I would not have coped well, and I probably would have got very, very sick and done another near-death experience. But I put myself into palliative care several years ago and refused all treatment that was going to lower my immune system. And as a result, today I have a wonderfully responding immune system. So when I got the vaccination, I got sick. Not sick, and it's not bad. It was just like having a flu shot. I know when I get a flu shot, I'm going to get a runny nose, I'm going to feel revolting, and I need to go, my joints will ache, and I'll go to bed. So what I do is that I take an antihistamine, I take Panado, and I go to bed. And when we could have some wine, I would have some wine to help put me to sleep. And that's how I handled it. And I'm afraid that this one was a bit more fierce in that the arm stayed inflamed. I've got my kind of arthritis means that all the muscles and the sheaths get inflamed. And so it stayed very sore for quite a while, and I used local non-steroidal anti-inflammatory, something like Panamol cream I rub on it. And otherwise, I just keep watching it. You know, I live with this kind of symptom all the time because I have an autoimmune disorder. And so, and the other thing that drives me nuts, I'm just going to add this out there, is that when they say, have you got any coughs and sneezes? It's the middle of blooming winter and we've all got allergic rhinitis. We've all got allergies going. If everybody answered yes to that, they would nobody would be getting a vaccination. You know, it's nonsensical. So I had my first vaccination at Alex Clinic. Early on, I was very privileged to go in there early on, and it took 2 hours, but it was a bit chaotic. I tested out the system because the government and the private sector were saying you can go anywhere to get your second shot. And so Discovery Health was much closer to me than Alex Clinic, and it's a lot easier to park there. So I went last week or the week before, and it was very difficult to get in the building. There were private security guards, about 15 of them, preventing me from getting in the building. I had to beg to get in the building. I had to fight to get my vaccine. But ultimately, I got my vaccine. They said, if you're on the EVDS, you should be able to get it. I did, but it was a hell of a fight. So I'm an activist through and through, and I tested the system. You've got to keep going. If you want to be safe and want to be vaccinated, you've got to be determined. Just do it. Don't mess around. It's very clear that you'll be dead if you don't vaccinate. Thank you. Bye-bye.
Thank you. Then the last question is for Dr. Zainab Mohamed. Just wanting to find out if cancer patients experience side effects from vaccination that are different from other people, and if you can share also your experiences as the oncologist.
No, cancer patients have exactly the same side effects or lack of side effects as others. For most of you, it will be the Pfizer vaccine. And I see the questions, is it best to wait for the Johnson & Johnson? It's one jab. The effect of both vaccines, fortunately, they're both active against the Delta variant. It doesn't matter which one you get. Take the one that you are offered. Take the first one that you can get. With the Pfizer, after the first dose, you have not as good a protection as you'd like, 33%, but that increases to about 88% after the second dose. So I would say please take the first vaccine that you can. The people that I've known that have had the vaccines, and I can only speak for my colleagues here, my experience is my colleagues. Some of the young ones had a very brisk reaction to the Johnson & Johnson. Me, I had hardly anything. So it differed. I've also never had COVID, by the way, although many of my colleagues have had. And I've worked in the COVID ward. So it's interesting how different people react differently. As far as the Pfizer, my parents-in-law, a lot of family members, older family members have had it, and now my husband had, and my brother, now that they've opened up for under 50s, and my colleagues, all on my matric group that I'm hoping are listening to me, they've had very minimal side effects. Most people have had minimal side effects. My cancer patients that have had it have had minimal side effects, and a lot of them are telling me they've had their vaccines and they felt okay afterwards, except for a sore arm. So no, side effects are not worse in cancer patients. Thanks.
Thank you, Dr. Zainab. One last question. I'm taking advantage of you because we're here online. This is one question that has come up a couple of times, but I'll take the specific one. I have lymphedema in my left arm. Do I need a letter from a doctor to get a vaccine in my right arm? Or will they give it to the right arm if I ask?
I don't actually know the answer to that, but I'm assuming that people would be sensible at the vaccination centers and not put it into the arm with lymphedema, because you would prefer it in the arm without lymphedema so that it's better absorbed, etc. So I really don't think that the vaccination center will have a problem. I mean, what do they do with people that have one arm or whatever? You know, yeah, I really think they would put it in if you have a problem with which arm do you say they normally do? The left arm or the right arm, whatever. I'm sure they'll put it in the other arm. Don't think that's a problem.
Thank you, Dr. Zainab. I just think it's important that if there are any concerns from patients and other people related to their existing or pre-existing medical conditions, they should share that information with the health professionals in the vaccination center so that they can be assisted appropriately and their concerns also taken into account. So we've come to the end of our webinar. I'd like to take this opportunity to thank our three speakers, Dr. Vicki, Dr. Davis, and unfortunately she had to leave the webinar earlier, and Dr. Mohammed, and also thank the CANSA team for arranging this, and for EP Digital for playing a significant role in the background, and for all the delegates for joining us and for raising such interesting and thought-provoking questions. This has been a very informative and educational webinar and a session. And we thank CANSA for making sure that those that are living with cancer and their caregivers are always informed and educated. A recording of this session will be made available on CANSA's website and online platforms. And the CANSA team will share, if not already done so, information on the chat. So thank you all, and please stay safe and stay warm. Goodbye.